pathology occurs due to the position of light chains within the renal tubules. Patients will undergo salient feature which is anemia present in about 80% of cases. أحيانا مش قليل بيحصل myophthisis اللي هو وجود infiltrating cells دي في البون مارو would affect the different clones of blood forming elements leading to leukopenia and thrombocytopenia. When we look to the bone disease, we find that the lytic lesions are very common about 60% of cases which show lytic lesions, بيبقى فيه osteoporosis, fractures, and as I said before, the myeloma cells are producing cytokines, interleukin 6 in particular, leading to this enhanced form of osteolysis. Just as a reminder for all of you what osteolytic lesions would look like, maybe السلايد اللي على اليمين اوضح شويه فيها البانشد areas في الهيومرس، ويمكن في حته فراكشر كمان موجوده هنا. This is a pathological fracture. A closer look at this fractured bone, as you can see, in a healthy bone, and this is the diseased bone, osteolytic, and this is why it was broken. Not uncommonly, وهي من الحاجات الكويسه اللي بنستخدمها الاكس رايز for screening lateral skull X-ray. It's not uncommon to find the punched out areas اللي موجوده في الراديوجراف اللي هي الvault of the skull would look like that. طبعا patient دوت had died. And these are the osteolytic lesions. Minimal diagnostic criteria for myeloma also exist apart من اللي انا قلتهم. You will find at least more than 10% of the infiltrate of the plasma cells present when you take a bone marrow aspirate. أقل من كده مش هتقدر تشخص multiple myeloma. But mind you, there is some forms of this disease non-secretory. The patient would have the myeloma cells, but you cannot detect them because they are not secreting any light chains at that point, and it's very difficult to diagnose. But to diagnose it, myeloma, you need at least 10% or more of plasma cells present on your aspirate together with the other clinical features. اليورين امبان اللي هو بيز جونز دي حاجه هيستوريكال مش بنعتمد عليها قوي في التشخيص، ولكن you can use it for screening together with the radiological screening as well. Now moving on to myeloma specifically with the kidney will be affected in various ways. كنت سامع الدكتور حسين بيتكلم على acute kidney injury بيقول pre-renal. We may have pre-renal conditions or renal or post-renal conditions associated with this disease. البري-renal بيبقى نتيجة الفوليوم depletion. أي عيان بيبقى عنده hypercalcemia بيبقى عنده polyuria. This polyuria may lead to dehydration. He may also have, due to the toxicity, the presence of this disease, a lot of vomiting, and diarrhea. Again, he is using fluids. Renal affection may be through the deposition of the light chains within the renal tubular walls or even the glomeruli, or occasionally not so common العيانين دول يكونوا stones نتيجة الهايبركالسيميا الموجودة أو الهايبريوريسيميا. كل ما السيرم كرياتينين بيبقى أعلى كل ما البروجنوزيس بيبقى وحش. ده during early diagnosis. We find usually these patients in the stages of 1.5 to 2 milligram per deciliter. لكن ال 1 year survival rate بيعلى كل ما السيرم بيقل عنين، كل ما السيرم كرياتين بيعلى، خاصة in patients that develop acute kidney injury and the dialysis. This carries the worst prognosis. Renal failure في multiple myeloma أسبابها متنوعة، ولكن mainly due to the presence of the cast nephropathy I will discuss the coming slides. Light chain deposition, amyloidosis, والhypercalcemia مفهوم سببها جاي من absorption طبعا. Occasionally these patients may develop a sort of Fanconi syndrome, some lower renal tubular dysfunction, and take good care not to use intravenous contrast in these patients because they are so susceptible to contrast injury and also susceptible to the development also susceptible to the nephrotoxicity of various nephrotoxic medications. The renal pathology as such, مع diversity of lesions اللي موجودة برضه بتتنوع. الكاست nephropathy being the most common and most prevalent, ولكن not uncommon إن احنا عندنا nephritis in interstitial nephritis may be due to the infiltration of the light chains within the kidney or the presence of hypercalcemia and hypoglycemia. Glomerulonephritis كذلك أنواعها وصفت من أول minimal changes لغاية focal and segmental glomerulonephritis. But the two main pathogenic mechanisms for renal affection in myeloma would be the intracellular cast formation or the toxicity of use with light chains. طبعا لو العيان dehydrated أو بياخد أي non-steroidal anti-inflammatory drugs أو concentration أو levels, serum levels of the light chains are so high it will make things worse. That depends على the aggressiveness of the disease. Cast atrophy is the most common pathological entity موجودة مرسومة تحت وهي عبارة عن light chains متحدة مع التان هورس فات بروتينز اللي بتطلع من الرينال تيوبز، وكل ما يبقى فيه dehydration وحتى تكون أقل كل ما الكاست هي هتزيد وتؤدي إلى acute kidney injury or failure quicker. This is the classical cast that it looks like. وهي الحقيقة pathognomonic of this disease being fractured وهي مكسرة لأنها it is so rigid having protein and having the light chains together and it's big and as it passes through the thin convoluted tubule it gets fractured to the cluster. That's why it's not fractured fast. لو حبينا نبص عليها بالimmunofluorescence we can detect the IgG portion of the hemoglobin, which is the most prevalent form of cast nephropathy. I don't want to go through a lot of details الحقيقة, لكن just to hint that light chain deposition disease is another entity of multiple myeloma affecting the kidney. With light deposition disease, we have the kappa fragments of the proteins that are incorporated within the basement membranes of the tubules. ولو بصيتوا هنا هنشوف ان الرينال tubules uptake these light chains through a specific receptor اسمه couplin, and once inside they should be metabolized ولكن لما بيبقى البيردن بتاعهم عالي وكتير it is much more than what the renal tubules can metabolize, and they start to escape through the interstitium, leading to an acute inflammatory reaction اللي بينتهي بالinterstitial nephritis. This is just the right, this is electron microscopy to show the deposition of the light chains على basement membrane. واللطيف المنظر الثاني على الشمال حد يقول لي ده زي وصفه كريستينا ويلسون نوبل diabetic glomerulosclerosis هو فعلا شبهه بالظبط, and this is associated with the monoclonal form of IgG deposition يشابه تماما في الباثولوجي what we see in the nodular form of diabetic glomerulosclerosis. Amyloidosis is another entity associated with myeloma, and it is said when you diagnose a patient with amyloidosis and kidney affection, you should probably think about the possibility that these patients may have myeloma, not primary amyloidosis. And usually this amyloidosis is of the lambda, not the kappa light chain disease. Well, this is electron microscopy to show the pleating of buffer and fibers بتاعت الاميلويد together مع الاميونوجلوبولين بتبقى متوفره وبيدينا الصوره اللي هي بتاعت الميكروسكوب. ولو سمعنا الكونغو راد في ورينا كلاسيكال upper chain refrangius. Hypercalcemia occurs in multiple myeloma نتيجة reabsorption of the bone. serum calcium لما بيعلى له complications بتاعته على النيرفس سيستم وعلى الكدني leading to vasoconstriction of the medullary vessels, acute tuberculosis. If the flux is too high within the interstitium, it will lead to acute interstitial nephritis. أو لو patient dehydrated, crystals بتاعت الكالسيوم precipitate causing stones. Occasionally, we can have a renal tubular dysfunction نتيجة deposition of the light chains. ودي بتحصل مع the forms of these light chains. and it leads to the Fanconi type of renal tubular acidosis. اللي هو بيعتمد على renal tubular acidosis, wasting of potassium اللي شافه الأطفال congenital disease, phosphate في اليورين, uricasuria, وفي bicarbonate wasting. Naturally, this is why we have this form of acidosis. علشان ما ننساش, the most common pathogenetic mechanisms of renal affection in myeloma is the intracellular gas formation or the direct tubular toxicity of light chains Yanina in amyloid. I talked about the interleukin 6 and 7 is possibly playing a very important role in driving the osteoblast to reabsorb the bone, or beta secreted under the effect of a specific factor reinvolvement in myeloma cells, enhancing the action of the osteoblasts. Now moving on to treatment, the best thing to do is to hydrate your patient with a lot of intravenous fluid, or you will get in trouble. Yeah, some dehydration will give a renal failure. Yeah, hypercalcemia كذلك هتؤدي إلى a lot of complications. So it's better to always hydrate the patient with a lot of intravenous fluid. You may give some loop diuretics برضه لها effect على lowering calcium. لكن bisphosphonates, which are very good drugs to treat hypercalcemia, are regarded very serious في حالات myeloma. And if you don't know how to use them, you better not to. Then you should decrease them according to the renal profile of as you get into trouble. The best available treatment is pulse steroids plus thalidomide and other newer drugs that will come to shortly. And the best, of course, but it's only for younger patients and those who do not have serious renal infection, is to do autologous stem cell transplantation like طبعا لازم يتبع chemotherapy. There is a possible role for plasmapheresis. Dialysis طبعا بنحتاجه لما بيبقى فيه indication. Now the recent Mayo Clinic guidelines started to personalize therapy for patients according to the stage, where some patients are high risk, intermediate, and low risk, according to various issues regarding age, renal infection, levels of free light chains اللي موجودة as دلوقتي مع بعض الجين studies, and accordingly we give the patients treatment. يمكن الأرض هي كانت بعض الفيروس treatment that I will go through quickly. أشهر هذه الدراجز الموجودة دلوقتي is a cortisone inhibitor. The cortisone inhibitor is going to be now further growth of the cells, even they cause the cells to die. هم بيأثروا على الجروث سايكل عن طريق inhibition of the growth related to beta. في other drugs tried كانت من thalidomide. Thalidomide احنا عارفين drug historical drug that was toxicity during pregnancy, ولكن it proved to be very beneficial in treating this type of disease. ولكن عندنا this drug rivelamide. It is a derivative of thalidomide القديم. It has been approved to treat mantle cell leukemia وكذلك المرض myeloma. له complications الحقيقة مش بسيطة غير الفتيج والمصل كراش والغرية والكلام اللي كان الدي بي تي الحقيقة الكونتنتيزم بتاعه عنيف جدا و other serious complications as you can see the toxic epidermal necrolysis is a very serious condition that gives the patient to secondary infection in a patient who has immunocompromised. Now the latest drug actually on the top of the list to treat this disease now is the bortezomib. Bortezomib has been showing wonderful results in a lot of publications, a lot of trials. We are not hematologists, we are not supposed to use these drugs that show the hematologists. احنا بنعالج العيان في الحته بتاعتنا لما يبقى عنده renal failure, لكن we should understand the bortezomib, which is a good drug to treat patients. Plasmapheresis has been used for many years. ولكن الكباسيتي بتاع these membranes at removing the light chains is not all that good. ان بعض الترايلز ورت الامبلانس قبل وبعد are much better, yet long-term follow-up ورت in plasma pheresis it is not all that effective, because we have a continuous formation of the free light chains اللي بتؤدي الى الكاستم بروتين الاسيدرين زي ما حضراتكم شايفين. We have to prevent the disease at its origin using the chemotherapy first. حتى لو عملنا plasma exchange وعندنا القدرة نعمل to exchange about 5 liters, still you will have more and more production of light chains that will produce the disease. ولو استخدمت أي نوع من أنواع الديالايزر مش هيقدر يتعامل مع molecular weight بالحجم ده. So until now there has been little success in attempts to use blood purification. Or perhaps perhaps there could be a new remedy now and a new rescue for these myeloma patients. وده الحقيقة undergoing a major trial all over Europe now. membrane جديد اسمه Theralite using a high cutoff technology اللي بيعملوا بورس واسعة جدا تعدي اللايت chains. وكل النتائج so far related to using these membranes have been proven quite an effective way of removing the light chains, and it's undergoing trial المفروض النتائج بتاعتها على السنة الجاية شغالة من decide new light if you like the European light chain trial. these membranes طبعا غاليين أوي ولكن كل الحاجات اللي بتبقى غالية بترخص مع الوقت. They are supposed to be very effective in removing the light chains, but it's not an actual treatment for the disease, and it could prevent the position of the light chains in the kidney. Providing you are treating with cortisone and you are using steroids at the same time and correcting the general condition of the patient and removing all the excess light chains, then the target area that you can prevent threatened and feared renal failure. فسبب حضراتكم موضوع complications عن شعب تخش في تفاصيل كل الترايلز دايما، ولكن كلها بتأكد ان this model therapy is good. My last slide ويقول ان كان شوية زيادة. Avoid dehydration and use intravenous fluid. With discontinuation of any nephrotoxic drug, particularly painkillers اللي عندنا أكيد بيبقى عنده pains نتيجة الفراكشنز. At times احنا بنبقى مضطرين نستخدم painkillers دي مع patients just to alleviate the pain. We may resort to narcotics, I think, would be much more safer than giving a patient a serious drug as this one. Early use of chemotherapy, steroids, and bortezomib with the availability of this Theralite membrane أو عندنا plasma pheresis نعمله علشان just to save our patient. As such, I want to thank you all for your time and attention. وعاوز نوه بس الويب بيج بتاعتنا تم تحديثها easyonline.com. هتلاقوا فيه كل المحاضرات الكورس بتاعت النهارده والكورسات اللي قبل كده وأضافوا other education material عن الدكتور سي شايشة. I think it will be of value to you. وأشكركم جميعا. ممكن ألاقي الشباب how to do the screening test that shows protein. هو البيت جوز بروتينز كنا بنسخن البول نسيبه يبرد. أول ما يبرد يوصل درجة الحرارة أقل من 50 بيبدأ coagulation.
المؤكد ما بين 50 و 75
بالظبط.
فوق 75 داير وتحت 50 داير. Very simple bedside test ممكن نعمله to suspect the situation to do further investigation.
بس اللي عاوز أقوله التست ده رغم من زمان كنا بنعمله واحنا الوقت كنا بنعمله إن هو not more that accurate anymore, but it's good for screening. أنا بحب أعمل نعمل سكريننج يعني جات لي ست كبيره واحده وهي فوق 65 سنه وعندها تحتين متحركين وعينين وبتصور من اعماق. I have to think على طول ان انا ترين الست المسكينه دي تكون ماينور. الكسر المونوكلوز ده is wonderful. Another thing I do hand x-ray ولابس stomach x-ray. كتير قوي مرات بتطلع من النقاشه خلاص بعد كده بعمل بلازما electrophoresis, refer to the hematologist. If the patient is in a failure, احنا هنعمل شغلنا والهيماتولوجيست هيعمل شغله. Thank you for this.